She's the pushy broad from the Bronx, New York. Follow her voice, a straight dog is nice. She's a pushy broad from the Bronx, oh yeah. Don't be surprised if you wanna listen twice. Make decisions, find the right choice. Know yourself better, find your own voice. It's okay if you need help today, cause everybody needs a little push. From the pushy broad from the Bronx, New York.
Good morning and welcome, Transformation Talk Network listeners. My name is Ellen Stewart, and I am the pushy broad from the Bronx. Welcome to my show, Recovery Recharged, where I share advice and support from experts in addiction and recovery. Today, I have someone on whose credentials can take up the entire 30 minutes of this program. I am so pleased today to have Dr. Marschall Runge with us. Doctor hails from Austin, Texas. He graduated from Vanderbilt University with a BA in general biology and a PhD in molecular biology. He then received his medical degree from Johns Hopkins School of Medicine and trained in internal medicine also at Johns Hopkins. In addition to all of the other wonderful and prestigious hospitals and academic centers he has worked for, he is currently an executive vice president for medical affairs and dean of the medical school at the University of Michigan and CEO of Michigan Medicine. I am so proud to have Dr. Marschall Runge here with us today to talk about his brand new book, The Great Healthcare Disruption, which is available for you for purchase on Amazon and wherever books are sold. The Pushy Broad from the Bronx is very honored to welcome Dr. Marschall Runge. Good morning, doctor. How are you?
Thank you, Ellen. It's great to be on your show. And love your theme song, by the way.
Thank you so much. I really appreciate it. We're going to have to get one from you because I mean, like you said, just your credentials alone could take the entire 30 minutes. In addition to this book, however, I was completely blown away by the fact that prior to this, you are also the author of a medical thriller called Coded to Kill. Is that correct?
Yes, that's correct.
When was that published?
That was published 2 years ago. And it's done pretty well.
Okay. All right. So it's kind of like a 007 thing here, Coded to Kill. That's what it sounds like. It sounds like Paul McCartney can do a theme song for that, right?
Yes.
James Bond thing. Okay. So here's a couple of questions I have immediately. The great healthcare disruption. 2 questions right out of the gate. Number 1, why the word disruption?
Well, I was trying to think about how to capture the intent of the book. And the intent of the book is to talk about all the things that are going to change the way we think about health, the way we think about recovery from illnesses, and the way we treat going forward. And there are many. And I chose disruption because I thought it'd be catchy, but it's in a positive sense. It's not, the world's going to end. It's that there are new things coming along and here that are going to really influence the way we live and our health.
We all have been getting a general feeling about this, especially with the advent of AI and all of the other things that are coming down the pike that we see in our everyday medical journey. So what gave you the little spark or maybe the aha moment that led you to write the book to begin with? Was there a defining event for you?
There were 2. So the first was that Forbes Books called me up, and I'd thought about writing a book, but Forbes is a great brand, and I thought,
of course,
that was attractive. But then what really got me going was thinking about why in the United States we're not doing better with health. We spend a lot of money on it. We have great technology. If I had a deadly illness, there's nowhere I'd rather be. But if you look at the health in the United States, and I found this as I was doing some of the reading about it, we are far from the healthiest country in the world. In fact, if you look at healthy life, average life span, we rank 60th, 60 in the world. and it's just shocking. So we spend way more money, and there are many factors that contribute to that. But I wanted to investigate what those are and how we might take some steps in the right direction.
Some of the things that have come out of your book and some of the little interesting statistics and charts, and I'm kind of very big on facts. I want to know facts and figures, is that in the United States, our lifespan currently is at about 76 years old, whereas Singapore is well into the 80s. Is that correct?
Yes, and let me take a brief break and just compliment you because I think one of the issues around healthcare these days is there's lots of conversation, but there is lots of scientific knowledge, and I think people should look to that scientific knowledge to help them understand some of the discussion around health.
So, what do you see happening? I mean, you have described this as a Promethean moment, which since the invention of fire, Doc, come on. I mean, is it really this exciting? I mean, I find it this exciting, but tell us why our readers should find it this exciting.
Well, uh, the Promethean moment, which you mentioned, named after the Titan Prometheus, was a moment that technology or energy or something is moves forward in such a rapid way, it's going to change the way we look at the world. And I think we are at that. And some of that's about AI. You mentioned that. And that term actually came from some of the early description of AI, which 2 or 3 years ago, I didn't really believe. Today, man, I'm a believer that this is a huge innovation. But the AI and other technologies are making it possible for us to do things in a way that was never possible before. And if you look at other data and look at the time that it took to implement new medical innovation, that has gone from decades to months. Amazing.
Totally amazing for sure. I first was introduced to AI in the medical profession 2 years ago with a mammography, right?
Hmm.
They give you an option now to use an AI generated program to really understand the mammography process and to give you much more well-informed data. I was completely blown away. So, what have you seen today? What does the book talk about in terms of the great inventions and the prognosis for AI in the industry?
Well, I'll start with AI. And I do believe that AI is going to transform everything about healthcare from an operational standpoint, from something as simple as you and I having a medical conversation, AI being able to capture that and create a very excellent medical note that I'd want to proof and make sure it's correct, but in moments. And that is a great satisfier to patients when we get permission always, and people want to have that. And then when with the physicians who have and other healthcare providers who've gotten so burned out with all the paperwork, this in our system is saving our doctors an hour and a half to 2 hours a day that they were just doing paperwork. I mean, think about that and what a difference that makes.
Exactly. And also,
So
I'm
there's
sorry,
there's
go ahead.
that. There's that. There's implications for all kinds of operational approaches that we take to healthcare. But I think even more, this interplay between AI and providers, and I think it has to be an interplay, um, is enabling people to understand their health. It's enabling physicians and other healthcare providers to be more effective and more efficient. And I see a great future for that.
It's certainly very exciting. It really opens the door up to many new things. And with that, of course, comes the idea of federal regulation and federal policy evolution. So, what do you see? And tell us a little bit about what the book says about advocating for bold federal policies and maybe even suggesting some brand new innovative government role in basic health care. What's your take on this, Doc?
Well, one thing I learned as I looked at all the countries that have done so well in healthcare and in average healthy lifespan, um, and you mentioned Singapore, which is right up near the top. Uh, Governments have become very engaged in what I'll call non-obtrusive ways. And so in Singapore, for example, well, maybe it's intrusive. There, it costs a fortune to have a driver's license, to have a parking place, up to $100,000. But at the same time, they have created a walking environment and a public transportation environment uh, that has people trying. They don't have to try to get their 10,000 steps a day. They get their 10,000 steps a day. And likewise, they have taxed highly processed foods, junk foods, so to speak, but they take the money from those taxes and they make healthy food much more available. So that's one general approach. The other thing that is true of all of our, what I'll call peer countries, wealthy countries that do better than us in health assessment, is that they all have some baseline level of healthcare that is government funded. Now, they trumpet it in ways that are kind of unfair. Everybody hears about Denmark and how great Denmark is, and they have the perfect public health system. Well, half the people in Denmark, they don't advertise this, buy private health insurance on top of that. And so it's not. So what I think is we have the opportunity to provide a baseline of health. Why is that important? That's important because if there's a baseline of health that is free or very inexpensive, people will get health care earlier and not wait so long and develop so much chronic disease. So I think that's one of the most powerful ways to reduce the chronic disease burden in the United States. And it's doable. And if I could say one last thing, which is I think a great advantage to me as I think about this is I've had the chance to practice medicine in private hospitals, but also in government health run services. For example, VA hospital, the Indian Health Service, what are called federally qualified health centers. And the level of care that's provided there is excellent. I can tell you just an article published this week showed the level of care from VA in cardiology, cardiac procedures, my area, was better for veterans at the VA than if they went to a local hospital. So lots of advantages there. And the government has also enormous purchasing power. So when we think about some of these drugs that are likely to be highly effective, like the weight loss drugs, they're very expensive. And my having a discussion with the CEO from one of the major pharmaceutical companies, they said, well, if the government was going to buy a very large amount of this medication, the price would be much less. And then the government could deliver it to people at probably a fifth of the cost.
So what you're talking about maybe is very, very similar to how veterans receive medical benefits for a lifetime and instituting or at least shoring up a universal healthcare system, at least in part, to cover people at an earlier age, and then maybe have it supplemented with a privatized health insurance, right?
Yes,
Something, some regulation.
absolutely.
Okay. Okay.
And so
So
both sides of the political environment have pushed back about that. On the one side, well, the government shouldn't be in the business. Well, the government has to be in the business. Take highways. Who's going to build a highway? Well, the government builds a highway. Who's going to provide, the facility to get clean water and dams and all these things? Healthcare is just one of those. But in addition, what what I think is clearly the case is on the other side of the argument is, well, we can't have two tiers of healthcare. That's a strong argument. But we have at least three tiers of healthcare. We have some public healthcare, we have a lot of private healthcare, and we have a lot of no healthcare. And so it's not
it's not working.
Yeah, and it's not working, and we have multiple tiers. So having two tiers with one adding on top of the other, I think is a solution that could work, although highly politicized across the board.
All right, so let's talk about the thing that most people worry about, and that is their daily trip to the pharmacy and their medications and how they should be regulated. Because I understand the obesity drugs, the GLP-1 drugs are on the market now. They seem to be the latest craze, and they are extremely expensive, and also medications that people need on a regular basis, like an asthma inhaler or an EpiPen. How do you see the future of healthcare moving forward in a positive direction to make these drugs more accessible?
Well, great question, and I've looked at this from all sides of the equation. I think that so it's well known that the cost of some of these same medications is much less in other countries, much less in Canada, much less in Europe, and that's a truth. It's also a truth that uh, innovation from US-based pharmaceutical companies far outpaces innovation from across the world. And part of that is that there is a significant margin generated by these drugs in the United States. So I think we have to figure out, well, how do we foster that innovation, uh, but make those drugs more available? And again, the one example I gave isn't the only example, but I think having these medications be purchased by an entity with huge purchasing power, uh, so that the drug companies know that they're going to get plenty of money to do their research and development, um, and the price to consumers is far less. I'll make another comment relevant to this. So, as you know, healthcare is an enormous part of our economy. It's 18, sometimes 19% of the GNP for the United States. And uh, part of that, if you look through our health system, people will pick out one little point, another little point. It's throughout the health system that we have intermediaries that take a lot of um, money out of the system, and one of the most important is in pharmaceuticals, and it's pharmacy benefit managers who, with for various business related reasons, uh, add very significantly to the cost of drugs. And so that's just the way it's evolved here. You can't take it apart overnight. Um, but I think we do need to take a step back and say, hey, there's not one silver bullet. There are 1,000 regular bullets, and we have to start looking at some of those because otherwise it'll end up with unintended consequences.
Without a doubt, there's no question. And there are many different ways that we want to tackle the big pharma. And we also want to talk about maybe the role that academic medical centers can play in this going forward, and maybe take some of the research and development away from big pharma and use it in a more altruistic way, so to speak. Okay, so that's possible. And I know that's what you work towards on a daily basis. This is a recovery show. And one of the things that really was amazing about the GLP medications, and you and I have talked about this before, is that now GLP-1 medications are being used to stave cravings in addiction. Can you tell us a little bit about that? Because all of us there are concerned about whether or not this is viable.
Yes, I'm a believer. And as you know, I was uh, on the Eli Lilly board of directors, and I got to see early phase studies that they went, and it was a surprise to everyone that these had such a profound impact on potentially addictive behaviors. They were developed for diabetes. Then it turned out that people taking these lost a lot of weight, and then examining why that is, unveiled that this is because when we do something highly pleasurable, we get a surge of dopamine in part of the brain. And it's that surge of dopamine that makes us, hey, I want some more of that. I want some more of that. And whether it's alcohol, whether it's drugs, whether it's sex, whether it's food, and there's a long list of these. Uh, and what these drugs do is they blunt that surge of dopamine. That doesn't hurt you physiologically in any way, but it makes it less rewarding to the brain. Um, and the way that this came up was that people, when they do these clinical studies, these huge clinical studies, they ask, if you ever participated in one, maybe some of your audience has, they ask lots and lots of questions. And what they found was people were saying, well, maybe part of why I'm losing weight is because I just don't feel like having a six-pack of beer at night anymore. And maybe I don't even feel like having a beer at all. And additionally, people who had really serious problems with narcotic opiate addiction were finding the same thing, that they just didn't feel that push. And before, I absolutely want to make a comment about opiate addiction. There are many causes, but the medical superstructure has to accept some of that because in making these medications available and making them available in large amounts, that has been a significant contributor, maybe the most significant contributor to this explosion of opiate addiction in the United States.
Yes, there have been many documentaries on that for sure. There's no question. So the GLP-1 medications are now blocking dopamine receptors and actually functioning like an amphetamine, right? Because that's what happens. You don't feel hungry anymore without the amphetamine effects, correct?
Exactly. Yes. Now you do get a little bit of an increase in heart rate. The manufacturers were confused by that, and I think that may be linked to the same pathway. It's not really ever proven, but it's not a dangerous and it's increase it, for 2 or 3 beats a minute.
It would be interesting to see how well it carries forward, and if treatment centers, residential treatment centers, and IOPs and OPs start prescribing GLP-1s for process addictions as well as substance addictions. And then, of course, there's going to be some evidence-based practice. So we'll have to see down the road. It's really too early in this game to see whether or not it's going to be effective. But I
Totally
understand. Okay. So you've got this great book, The Healthcare Disruption. It's a really easy read. It's available on Amazon. Tell me personally, from writing this book, what your most surprising discovery was. When you put all of this stuff together, did you say, oh my goodness, I can't believe this has happened?
Um, I had a sort of a big epiphany and then another surprise. So the big epiphany was that there is a lot of good going on in innovation in healthcare, and I knew some of it. I certainly didn't know all of it, and that that really tremendously encouraged me about the future of health. I think I hope and I think it's feasible that in 10 or 15 years, these things don't happen overnight, that the health of the United States, rather than getting worse, can actually start getting better. We're a smart country. We've got resources. Why not? But the other I knew about, but the other just watershed moment was how differently wealthy countries have the United States, rather than getting worse, can actually start getting better. We're a smart country. We've got resources. I'm getting a little feedback, but anyway, the difference is that they have invested in health as an infrastructure issue. And I think we have, and I've seen it during my 40 years in medicine, it has become more and more and more of a business, and a for-profit business, even for non-for-profits. I've worked for non-for-profits my entire career. But I think rethinking that and how we could invest in health as an infrastructure issue for the United States, rather than thinking of it as 1,000 or 100,000 businesses. So that's what really kind of blew my mind.
That's what really hit home for you. And I understand that. It's very optimistic. And I'm really thrilled that you have really put some new potential into this entire thing. And the great healthcare disruption really reads in a very flowing, very optimistic way. And I really appreciate that. So I want you to leave us with one thing, because we have about 30 seconds left. Let us know what you think the prognosis is for the future, next 5 to 10 years.
I'm optimistic. I think the prognosis is good. I think we have lots of attention on health. We have a scattering of ideas, but I think they'll come together, and I think we'll end up as a healthier nation if we can follow the science. So I'll say that over and over as you started the show, Ellen. Let's follow the science.
Fantastic. Thank you. Dr. Marschall Runge. The book is The Great Healthcare Disruption. You can find it on Amazon. It's a really good read. Thank you so much for being here today. I want to have you back as a consultant from time to time. I love having you here. Thank you so much. This is the Pushy Broad from the Bronx saying thanks for listening, and we'll see you next time. This is Ellen Stewart, the Pushy Broad from the Bronx, saying thanks for listening, and remember, everybody needs a little push.
From the pushy broad from the Bronx, New York.